Thank you. Can everyone hear me in the back? Yes? Yes. If I stand here, do you not see the screen, or can you see the screen? I'm thinking you people. Okay. Let me know if you're having trouble. So it's a great pleasure to be here, and it's heartwarming to see how many people come to this kind of education program, because education is one of the most important powers that you possess to fight Parkinson's disease, whether it's your Parkinson's disease or someone you love has Parkinson's disease. The two most important needs are education and exercise. So this is a really important thing, and it's a terrific program that Nancy's put together. So as she said, I'm here to talk about Goop soup. And what I mean by that is your internal organs. You don't ordinarily think of your internal organs as being under neurologic control. But in fact, nothing on your insides works well unless the nervous system is working well. And we know that in Parkinson's disease, this part of the nervous system is damaged and causes lots and lots of symptoms that sometimes physicians feel ill-prepared to deal with, and patients and their family members often feel ill-prepared to deal with. So let's talk about what I mean by that. So I think probably everyone in this room knows that neurologists focus a lot on the chemical dopamine, right? Everyone knows that word, and the medicines you take work on this dopamine system. And that's because most of what we know about Parkinson's disease, and virtually everything that we treat about Parkinson's disease, has to do with the movement disorder. It's a movement problem. And here, this picture shows the symptoms, some tremor, this kind of stooped over posture, short shuffling gait. That's typical of Parkinson's disease, and that's the most visible expression of the disease. It progresses in a very stereotyped fashion from mild symptoms on one side to symptoms on both sides to more severe symptoms, problems with balance and walking, and ultimately to really quite significant disability and the ability to move around. And it's been known for many, many decades that one of the most critical features of the brain illness, and this is a picture of your brain if it's sliced right down the middle. So you're looking at the middle portion. And this area, your eyeballs are here. Spinal cord is there. And in this picture, this is a nerve cell that's in an area called the substantia nigra. Does everyone know that terminology, substantia nigra? It means black stuff, because this part of the nervous system is dark just to the naked eye if you slice the brain. And what the nerve cells that live there, neurons that live there, project. So nerve cells have a cell body where the DNA is, and then these long projections so they can go to other parts of the nervous system and communicate with them. So what happens in Parkinson's disease is these cells degenerate. These cells produce 80% of the dopamine in the brain. Dopamine is an important chemical for movement, mood, and motivation. And so what happens is the areas of the brain where the dopamine goes become deficient in dopamine, and you see these kind of typical motor signs of Parkinson's disease. And so patients are focused on these problems, doctors are focused on these problems, and the vast majority of the research in Parkinson's disease is focused on ways to either stop those nerve cells from dying or replace the effects of that death by increasing dopamine in the brain. And we're fairly good at treating the movement problem of Parkinson's disease for many years. Although people do have significant disability, it's much better than it used to be. And you can tell by looking at me, I've been around for a while, so I know that things have really changed over the decades. So, and this is, I don't want you to be able to read this necessarily, but this is a very important lesson I learned relatively early in my training. So one of my colleagues was seeing patients with Parkinson's disease, and he showed me this thing that a patient had brought in. It was a piece of paper, and she had Xeroxed this picture of a person, and then she'd handwritten all the things that bothered her. And the reason that this spoke so much to me is because most of the things she'd written actually didn't have to do with what we consider to be the typical movement symptoms of Parkinson's disease. She said that it was difficult to swallow, and her head felt foggy, and she was having problems with drooling. And her bowel movements felt different, and there was pain. There were all kinds of things that didn't fit into that kind of typical movement disorder of Parkinson's disease. And that's a really important lesson, and I always think about this when I see people in the clinics, that sometimes we're pushing a treatment for symptoms that we think are important, but our patients actually have a lot other symptoms, a lot of other symptoms that they think are important. And the other really important lesson I learned one day was I was in clinic with a person I'd been treating for more than 20 years, and he was really significantly disabled. He was quite elderly. but he had problems with his thinking and memory. He had hallucinations from the medicines, and had really severe problems with mobility. And his wife said to me, you know what our number one problem is? And thinking that I'm a smart neurologist, I thought, hallucinations, cognitive impairment, difficult to move around. And what was her answer? Constipation. And that was a really important lesson for me as well. So a lot of what we have to do is listen to our patients and figure out what's really bothering them. So the part of the nervous system that controls your internal organs is called the autonomic nervous system. And you know we doctors like fancy names. Autonomic just means the involuntary or unconscious. You don't have to think about your heartbeat or your stomach emptying. These are things that happen on their own. And there are two parts to the autonomic nervous system. One is called the parasympathetic autonomic nervous system. And that's the way to think about this is the resting and digesting. So this is what your body, your internal organ functions do when you're just at rest or if you've eaten a meal, etc. So there's a nice lion who's had a delicious meal and is just resting and digesting. And then the other part of the autonomic nervous system is the sympathetic nervous system. And the way to think about that is fight or flight. So this is the part of the nervous system that tells all your internal organs what to do if you're running away from someone or if you're fighting with something. So it's the complete opposite. And at any particular time, there's a balance between the parasympathetic nervous system and the sympathetic nervous system that's dictated by what state you find yourself in. If the house is on fire, your sympathetic nervous system is going to really fire up into action. And if you've just had a big meal and you're sitting in front of the Super Bowl game, then it's this rest and digest part of the nervous system. Does that make sense to everybody? So, all right. So now you're probably wondering how the brain attaches to the internal organs. How does it get from one spot to the other, this control system? So this is the parasympathetic nervous system. So that's the rest and digest part of the autonomic nervous system. And so what you can see here is here's the brain, and here's the spinal cord. And the parts of the nervous system that are involved in the parasympathetic or rest and digest part are up here at the top of the lower part of the brain, and then down here in the lower part of the spinal cord. And so nerve cells that live there send those long projections to the actual organs. So you don't really think about this, but there are nerve cells that are around every single one of your organs that allow the brain and the nervous system to control whether you're in the rest and digest mode or whether you're in the fight or flight mode. So when you're in the rest and digest mode, what happens is your pupils are constricted. They're not dilated. You're salivating. Actually, usually that's to help with the kind of eating and digesting. Your heart rate slows. You don't have to be all ready to pump blood to all your muscles so you can run or fight. Your airways are narrow because you're not needing a lot of oxygen, just the amount that you normally need to breathe. Your stomach and your intestines are stimulated. So usually this is a time when you're, as I said, resting or digesting. And then this is also the part of the nervous system that allows your bladder to be active so that you can empty your bladder. And also it's the part of the nervous system that controls sexual function, the arousal side of sexual function. So the development of erections or arousal in women. So that's the kind of resting part of the nervous system. And then the sympathetic nervous system, the fight or flight side, they're different actually. These nerves live in a different part of the spinal cord. And they do things like open your pupils so you can get more air, more light and see better. Inhibit salivation, so your mouth gets dry when you're excited or anxious, right? Increase your heartbeat so you're ready to pump all that blood to the muscles that you'll need to fight or flee. Relax the airways to get more oxygen to supply the muscles. Your stomach and your intestine, that all slows down because you don't need to be digesting. What you need to be doing is getting as much blood to your muscles as possible. And then also there's a stimulation of sugar release, so there's a fuel release from your liver so that you have that energy. And this is the part of the nervous system that is involved in actual ejaculation or orgasm. So this is the other part of the sexual part of the nervous system. Does that all make sense to everyone? And remember, it's not as if you're all in one state or all in another state. These two systems are in balance depending on what's happening. So this is the normal state. Now, this is a slide that summarizes how often Parkinson's disease patients complain about problems that are related to this part of the nervous system. And we're going to go over each one of these categories. So gastrointestinal, so these are things like constipation and bloating and gas. And 95% of people with Parkinson's disease complain about this. 95% of patients have problems with gastrointestinal function. And this column here is, this is from a study where they saw how related those complaints were to changes in quality of life. So my patient's wife, who said their number one problem was constipation, was because constipation was really interfering with their quality of life. And this column is called the p-value, which is basically the strength of the association. So the smaller the number, the stronger the association is, basically, or the more relevant it is statistically. So 95% of people have gastrointestinal problems. 100% of patients have some complaints related to the bladder. About almost 2/3 have problems with cardiovascular, and that usually is problems regulating blood pressure, which we'll talk about a little bit. Almost 3/4 thermoregulation, so the thermostat, controlling whether your body is too hot or too cold, or whether you're sweating or not sweating. And then 95% have problems with sexual dysfunction. But because a lot of Parkinson's is a disease of aging, a lot of people who don't have Parkinson's disease also have trouble with sexual function. So it's actually not as significant. That's kind of interesting, not significant compared to the general population. So that's how often we see it. And so we're going to start with gastrointestinal dysfunction. So here's an invisible man eating an apple. And you can see the, up here we're really mainly concerned with swallowing, getting things down into the esophagus, which is behind your windpipe. And that's very important because you have to be able to keep food out of your windpipe. And the first place for it to go would be into the windpipe. So we'll look at that in a little bit more detail. And then you get the stomach, and then lots and lots of small intestine, and then the large intestine. So that's the whole kind of pathway in the gastrointestinal system. And you can see on this slide that a lot of symptoms come from gastrointestinal dysfunction in Parkinson's disease. So these include everything from drooling, having trouble with swallowing, a bloated feeling, nausea, belching, pain in the belly, constipation, flatulence, there's a lot of excessive gas, problems eliminating the stool, what we call defecatory dysfunction, and ultimately weight loss, which is very common in Parkinson's disease. Patients lose an average of 15 pounds over their disease course, and partly it's related to all this gastrointestinal stuff. So drooling and abnormal swallowing are kind of related. We're going to go into that next. And then these other ones, this bloating, nausea, belching, abdominal pain, constipation, and gas, are all similarly related because they are caused by slow transit. So it takes a long time for food to get from one end to the other when you have Parkinson's disease. And that's because your entire gastrointestinal system has nerve cells in the wall. And what happens is the nerve cells are active, and then the muscles in the wall of the intestines will squeeze, and that's what moves things. And then the next muscles will squeeze, and that's what moves things from one end to the other. So people who have abnormal nerve input into their intestinal system, it takes a long time for food to move from one end to the other. So the stomach doesn't empty the way it ordinarily would, and so you're bloated. Sometimes there's nausea. You can belch. And at the other end, there's a lot of problems with constipation related to slow transit. And then you get a lot of fermentation in the intestines, and that causes a lot of lower intestinal gas. And then something that's not really well appreciated is the way that the intestines empty to actually have a bowel movement is not regulated properly. So not only is it taking a long time for food to get to the end of the intestines, the system for kind of which muscles are relaxed and which ones contract also doesn't work properly. So there's problems, people tell me all the time, problems pushing the stool out. Even if it's not hard stool, problems pushing it out. So those are the typical things that we see from gastrointestinal dysfunction. And then here's another picture, similar, kind of in the mouth. People tend to have a lot of salivation, problems with coordinating the swallow, so they can have problems with coughing when they eat or drink, especially liquids, and some problems with penetration of food into the windpipe and even the development of pneumonia related to the bacteria and food getting into the lungs. And then the esophagus, which is your swallowing tube, a lot of people will have problems with even motility there, so slow swallowing even in the esophagus. Some people have trouble with the muscle that keeps the esophagus separate from the stomach, and the stomach produces a lot of acid, and if the acid escapes up through that muscle, then you can have heartburn or reflux, which is a common thing as well. And then as you get farther down, this, as I said, the slowness of transit in the intestines causing constipation, trouble emptying the bowels. And these are just the different areas that we talked about. So salivary glands, the pharynx, which is up the upper part of the throat, back of the throat, stomach, and then the intestines. So let's talk a little bit about swallowing, because remember I put a bracket around drooling and dysphagia, drooling and swallowing problems on that prior slide? And that's because people complain about drooling a lot. It's a very common complaint. It's very embarrassing. It causes a lot of decline in quality of life. And overall, over the course of the disease, almost 80% of patients will complain about drooling. Very, very common. But it's not that people with Parkinson's disease make too much saliva. There are good studies, in fact, to suggest that people with Parkinson's disease make less saliva than people without Parkinson's disease. But the difference is that swallowing, a lot of swallowing is unconscious, and the rate of unconscious swallow is lower in Parkinson's disease. So if you swallow less, you're going to have more saliva in your mouth. And there's also a tendency for the head to be pulled forward in Parkinson's disease, even a little bit. And so then the saliva is going to be pooling in the front of the mouth. And so that's a real common problem. Now, how about dysphagia? So dysphagia, so there's a reduced rate of swallowing, which is very common in Parkinson's disease. But even those people are swallowing normally. They're able to protect their airway. But about 30 to 80% of patients will have abnormal swallowing. But interestingly enough, only about half of them are actually aware that they have it. So when they get tested for a swallow study, you'll find that their swallowing is not normal, but they haven't actually been aware that it's abnormal. And it's most commonly bothersome as the disease progresses. So later onset or later in the disease course, people will complain. And the most common abnormality is that the swallowing is slow. You hear slow a lot because it's slow swallowing. And it's a very complicated pattern of movement that controls swallowing. And so if it's slow, then there's a chance that the food is going to kind of go out of its little ball and end up in parts in the back of your throat. And then when you breathe again, it can end up in your airway. So this is a cartoon that shows you what happens in swallowing. So this, again, is a person cut through the middle here. And you can see there's his nose. This is his nasal cavity. Here is the soft palate. So there's the hard palate in the front and the soft palate in the back. Here's the tongue. And the blue thing here is what's called the bolus. So no matter what you eat, if it's liquid or solid, the first thing you have to do once you chew it is you have to form it into a ball. You can imagine how difficult it is to form liquid into a ball, but that's what you do, and that's called the bolus. And then what you have to do is you have to close off your nasal cavity with your soft palate, otherwise the food's going to come out through your nose. And you have to end up closing off the trachea. So this part here is the windpipe. And remember, you've got to get into the esophagus, which is behind the windpipe. So then as you swallow, this little flap comes down and covers up the windpipe, and that's called the epiglottis. And then the bolus, the food gets to go down into your swallowing tube. And so what happens is if this is slow or poorly coordinated, you've got some food or liquid hanging around in the back of the throat, and then when the epiglottis opens up and the breathing starts again, that can go down into your windpipe. So people will commonly notice that if they're drinking liquids, that they'll cough after they start to breathe again. And that just means that something's gone down into the windpipes. That's an important symptom to be aware of and to tell your doctor about if it happens. So here's from a study from 2011 that looked at the occurrence of drooling and swallowing problems in Parkinson's disease. And they looked at it based on the Hoehn-Yahr score. Who knows what the Hoehn-Yahr score is, or stage of disease? Is that a familiar concept to you? What stage is my Parkinson's? Stage 1 is symptoms on just one side of the body, and the neurologist doesn't detect anything on the other side of the body. And Parkinson's disease always starts on one side. And then stage 1.5 means there's some change in facial expression or posture. Stage 2 means there's symptoms on both sides of the body. It's usually, most people are in stage 2 at about 3 to 7 years from onset. And then stage 2.5 means that you have some trouble with balance, but you're able to correct yourself. Stage 3 means that if you have something that perturbs your balance, like the most commonly the neurologist standing behind you in the clinic pulling back on your shoulders, that you cannot correct. You have to take multiple steps back and you have trouble correcting your balance. And stage 4 means severe difficulty with walking but still able to walk. Now there is a stage 5 of Parkinson's, people who can't walk at all. But the way we manage people now, it's rare for people to really end up in that stage 5 because the medicines are pretty good at keeping people on their feet for most of the disease course. And you can see, and this is the number of people who are in each of that group in this study, and you can see that as time goes on, that there's some drooling and some problem with swallowing even in early disease, but as time goes on, it becomes very common. So by stage 4, 65% of people have drooling and 46% have swallowing problems. And so, yep. Yeah, you know, neurologist, dys means abnormal, phage means swallow, so abnormal swallowing, correct. Quite all right. And this is true, you know, this is true of all of the symptoms I'm going to talk about today. They're all present to some extent in early disease. They may even start before the first movement signs start in Parkinson's disease, but they tend to get worse over time. There's a disease called multiple system atrophy. Has anyone ever heard of that? So multiple system atrophy is a variant of Parkinson's where the autonomic changes are very prominent early on in the disease and become more and more prominent, so out of proportion to the severity of the rest of the disease. But we're talking about Parkinson's disease here, not multiple system atrophy. Okay, so that was drooling and swallowing. The next part is the upper gastrointestinal, what we call dysmotility. So this is what I mean by the slow transit. So once the food gets into the stomach, there's a sphincter, which is a muscle at the top of the stomach and at the bottom of the stomach. So when you swallow, the muscle at the top relaxes and lets the food go into the stomach, but the muscle at the bottom of the stomach is constricted. And then after you swallow, then that top muscle constricts again. So that puts everything in the stomach. Then the acid is secreted, and it churns around a little bit, and that does the first step in digestion. And it's important for those muscles to work properly so the acid doesn't come up into the esophagus and give you heartburn, reflux, and so that the food doesn't leave the stomach until it's ready to go into the small intestine. So more than 60% of patients with Parkinson's disease have problems with their upper intestinal motility, including slowness of the food to get into the stomach in the first phase, and decreased efficiency of that muscle at the top of the stomach, so you get this kind of heartburn and reflux commonly, and then slow stomach emptying. And this is important for two reasons. One is it causes symptoms. It causes you to feel bloated. Sometimes it causes you to feel too full when you're eating so that you can't finish the meal. But the second thing is that it's important to understand that the medicines to treat Parkinson's disease are not absorbed in the stomach. They're absorbed in the small intestine. So in order for levodopa to work, Sinemet, it has to get into the small intestine, so it has to leave the stomach. And if the stomach emptying is slow, it takes longer for the medicine to be absorbed. And this is the reason that we commonly say, take your medicine at least 30 minutes before eating, because we want to make sure it's absorbed before the food goes in there, because the food interferes with the absorption of the medicine. So slow stomach emptying can actually cause people to feel like their medicines are less predictable. And then when we get to the lower intestines, constipation up to 90% of people, and that's usually related to slow movement of the food stuffs through the large intestine. And the reason is because the main function of the large intestine is actually important in the immune system. It's important in certain aspects of metabolism, but mainly what it does is it absorbs water from the food. So the whole way the food is moving through that lower intestine, water is being absorbed out of the food into the bloodstream. And since it takes much longer to get from one end to the other, too much water leaves the stool. And that's why the stool is hard and dry, which is one aspect of constipation. And then the other aspect is controlling, getting it out of the intestines. And so defecatory dysfunction, so defecation is the process of having a bowel movement. And it's a very well coordinated system because there are two muscles that are really important in eliminating stool from your body. There's something called the internal anal sphincter, and that's a muscle that's controlled by reflux. So when you have to go, that muscle relaxes. But because we are social beings, we also have an external anal sphincter, which you have control over. So you can prevent having a bowel movement, even though the reflex wants to have one, by controlling that anal sphincter. And so the process of eliminating the stool requires that both the internal sphincter, internal muscle, be relaxed, and the external muscle be relaxed. And there's an interesting problem in Parkinson's disease where sometimes that's not coordinated. So sometimes the external sphincter muscle is tight and it's hard to propel the stool out. So people will say they just can't, they just can't get it out, can't get the stool out. That's called paradoxical muscle contraction. And that's because the degenerative process of Parkinson's disease, the same thing that's causing the brain cell death, is also in the spinal cord where those nerve cells live. So that's why it happens. So what's constipation? It's interesting because people don't all agree on what the definition of constipation is, but gastroenterologists define constipation as having fewer than 3 bowel movements per week. Other people have their own definitions. And one thing that's actually interesting in Parkinson's disease, I think, is that the constipation that we see in people with Parkinson's disease may start years before the first tremor or the first slowness or the first other observable sign of Parkinson's disease, up to 20 years before. And because of this, people tend to be used to a bowel movement frequency that's less regular than people who don't have Parkinson's disease. So I'll have people and I'll say, do you have constipation? And they'll say no. And I'll say, do you have a bowel movement every day? And they'll say, no, I have a bowel movement every other day, sometimes every third day. So part of it is being used to a kind of constipated elimination system just because it's such a gradual process and people have it for years before. And this is a really kind of interesting statistic. So 80% of people, there are ways to measure colonic transit time. There are markers you can use. And so this has been studied in Parkinson's patients, and 80% have slow colonic transport, which goes along with 80% being constipated. So a normal person has an elimination time of up to 39 hours. Late Parkinson's disease patients, it may take them 130 hours to get the food from one end to the other. So you can see how that's a huge abnormality that would allow all that water to be absorbed from the stool to be hard, and also contribute to the pain and the bloating and everything else that goes on in the abdomen. And even early Parkinson's disease patients, it's more than twice as long as the normal colonic transit time. And so this is just a slide that I have in here to talk about constipation prior to Parkinson's disease. So there have been a number of studies that have kind of unwound over the last couple of decades where people have been enrolled in midlife and then followed, usually to look at the risk factors for heart disease, for example. And so in these studies, people are examined at certain intervals. They collect data about certain things. And then they look at the risk factors. And this is a list of several, 2, 4, 6, 9 different studies that looked at people either in a prospective fashion where they enrolled them at a time and then saw them every year over decades, or they did what's called a case control study where they took people who had Parkinson's and people who didn't and looked back to see whether they had constipation. And so there's a lot of numbers on this slide, but I just want to direct you to this part with the red square. This is called a relative risk, which means that what is the risk of a person with Parkinson's disease having had constipation before the onset of Parkinson's disease. And this number is that number. So in this particular study, it was more than twice as likely. In this study, it was more than 4 times as likely. And these studies have suggested that people who have constipation in midlife, fewer than 1 bowel movement a day, are about twice as likely to develop Parkinson's disease as people who don't. So this constipation, but it probably isn't a risk factor. It's probably an early sign of the disease, because some more recent studies have suggested that the nervous cell changes in Parkinson's disease may start in the intestines or in other organs of the body and then spread up the nerves into the central nervous system and ultimately into the brain. So now you might be thinking, if you don't have Parkinson's and you're constipated, that you might be wanting to worry about this. But just to give you an idea, the lifetime risk of Parkinson's is about 2%. And so the lifetime risk of Parkinson's for constipated people is probably about 4%. So it's really not much to worry about. And constipation is a very common thing. But it's more interesting to researchers who want to try to figure out how to diagnose Parkinson's earlier so that we can find something that would slow the disease progression or even prevent people from getting Parkinson's. So that's why it's interesting. So let's talk a little bit about defecatory dysfunction. This is probably something that you don't have, chat with your friends about over dinner. You might probably don't chat even with your doctor about it. So the rectum can hold a lot of stool. It's kind of a holding chamber. And as it fills up, then you get pressure in there, which helps then to cause the defecation. And it's interesting, in Parkinson's disease rectum, it doesn't raise its pressure well enough, which makes it less efficient at emptying. And then when you're trying to squeeze it out, the stool out, you don't get as much of an increase in pressure. So when people tell me, I have trouble pushing out the stool, that's what they mean. They can't push it out. And often the anal pressure, which is the pressure in the muscles that hold the stool in, will go up instead of down when the rectal pressure goes up. So ideally, your rectum fills, you feel like you have to go, you increase the pressure, you relax the sphincters, and out it comes. But interestingly enough, a lot of times both of those pressures go up, so the more you push, the harder the muscle tightens, and so you can't release, you can't relax the muscle to let the stool come out. So you're also not increasing the pressure enough in the rectum. People with Parkinson's have trouble pushing the stool out, so have trouble raising the pressure in their abdominal cavity. And as I said, the anus, the muscle may actually tighten paradoxically. So that's why this has not been really recognized until fairly recently in Parkinson's disease, but it's a significant cause of problems. Now, one thing that's important is that all these gastrointestinal symptoms, in addition to annoying the heck out of you and annoying the heck out of your spouse, also have a certain amount of risk. So this was a study that looked at 208 Parkinson's patients, and they had drooling, swallowing problems for liquids and solids, and constipation. And they kind of were across the spectrum of weight. So some people were underweight, some people were normal weight. And this is typical of the American population now, significant number of people who were overweight or obese. And what they found was that overall, of all these patients, even the ones who were overweight or obese, 17% were at risk. So they had some measure of their dietary adequacy or their nutrition that meant that they were undernourished, malnourished, fairly commonly. And people who had weight loss related to their disease, if they had a lot of weight loss, they had severe nutritional risk, so actual risk of being malnourished. And the people who were more likely to be malnourished are ones that had more severe disease. They were taking more medicine, but this is not to imply that the medicine caused the risk. It's that if you have more severe disease, you take more medicine. So that's just another measure of how severe the disease is. And they actually had a lot more, sorry, I'm losing my thing here. A lot more of these complications related to the autonomic nervous system. So their autonomic nervous system wasn't working as well as the people who were at risk. And this is important because there are things that can be done to intervene in people who are at nutritional risk to make them healthier. So sometimes if you see a nutritionist or start using something like a supplement like Boost or something, it's to improve that, reduce that risk of nutritional problems. Let's talk a little bit about treatment. The gastrointestinal stuff. So for drooling, remember I told you that the main problem with drooling is less frequent swallowing or inefficient swallowing. And that's because most of the swallows that people have, they haven't thought about. You know, you swallow when you drink or you eat, but when you're not drinking and eating, you swallow as well. And so that's reduced in Parkinson's, and the head forward tends to cause the drool to come out. But if you suck on sugarless hard candy or chew gum, you will trigger a conscious swallow. So you can swallow more often if you're chewing gum or using hard candy, sugarless, because of the saliva problem in Parkinson's. Dental decay is actually more common in Parkinson's patients. You don't want all that sugar. There are medicines that block what's called acetylcholine. The one I use is glycopyrrolate or Robenol. Some people use atropine drops. And that just dries up the saliva. Remember, the problem isn't too much saliva, but if you dry it up, then there's less of that saliva to pool in the mouth and come out. And the thing that's most effective, actually, is botulinum toxin injections. So botulinum toxin reduces the release of the chemical from the nerves that stimulates the salivary glands. And so if you inject it into the salivary glands in the parotid gland and also in the submandibular gland here, you reduce fairly dramatically the production of saliva. Medicare generally won't pay for it unless you've already failed an oral medication, but this is an extremely, it's easy for the doctor to do. It's pretty well tolerated. Some people don't like the sensation of the toxin going in, but it works for 3 months. You just come in every 3 months and get an injection into those glands, into the salivary glands. For dysphagia, for the swallowing abnormality of Parkinson's disease, there aren't a lot of good studies about what works. There are some things like if you strengthen the muscles of breathing, actually. There's a device here that's a kind of a closed system that you blow into, so there's resistance to it, and as you blow into it, then you increase the strength of those muscles. And so there's a study that suggested that people who did 5 breaths a set and 5 sets of 5 breaths had improved swallowing safety, but it wasn't a very pronounced effect. And I don't know that this is even clinically available. It's an interesting study that looked at video-assisted swallowing therapy. So what they did was, has anyone here had a swallow study? So they did a swallow study with X-ray, and then they showed it to the patient, and then they showed what normal swallowing looks like, and they said, this is what's going on with you, this is what's going on in a normal swallow, and then they trained them with giving them this feedback of looking at their own swallowing study. And actually, that technique improved swallowing and improved quality of life, so that's kind of an interesting technique. And then, has anyone here had LSVT loud? So LSVT loud is a treatment that was developed to improve the loudness of speech by teaching people to make stronger, higher amplitude movements with the muscles you use to make speech. And one study looked at the effect of LSVT loud on swallowing, and found that the tongue moved better, and that normal tongue movement is very important in coordination of swallow. The thing about LSVT is it's become a kind of a commercial enterprise, and so the studies have basically stopped. But that's an intriguing one. And then there are things that are just kind of sort of common sense things that are often recommended. So one thing that's common in Parkinson's disease is it's difficult to do 2 things at once. So if you're eating and you're having a conversation or watching television or something, your brain is kind of split. So part of your brain is watching TV or having a conversation. Part of your brain is concentrating on swallowing. And so what happens is the swallowing deteriorates and you're more likely to have problems. So people who have significant swallowing problems should eat in a quiet place and not have a conversation when they're eating. All their focus should be on eating. They should not talk when they're eating, because when you talk, your windpipe opens and then the food's going to go down in there. It's best not to eat when you're tired, because your swallowing is less efficient when you're tiring. And if you're someone who has motor fluctuations, where at some times during the day your medicines are working and other times during the day they're not working, then you eat when the medicines are working. You eat when you're on. Also, to sit close to the table, and you should always eat with your head upright, sitting upright and then with your head up. And then not lay down after you eat, because then the food can come back up through the esophagus, and you can be at risk of aspiration or food penetrating into your lungs. Small bites, chewing thoroughly, and then something that's often recommended is a double swallow. So remember I said that if your swallowing isn't efficient, after you swallow, some of the food can be left in the back of your throat. And when you start to breathe again, then it can go into your lungs. So the purpose of the double swallow is to clear the rest of the food that's in the back of the throat. The way you do that is you take a bite, chew, swallow, swallow, and then take a liquid, and then swallow again before the food goes back in. Yep, botulinum toxin. Yep. Yep. Another thing that's helpful is thin liquids are the hard. You can imagine thin liquids are the hardest things to keep into a ball, to throw to the back of your throat and swallow. And so thickening the liquids is very good for people who have coughing when they're drinking thin liquids. It's also recommended that you limit the time that you're eating, but not rush when you're eating. It's for some people who are slow eaters, and this is where it comes into the kind of nutrition area. You should eat your highest value foods first, the things that have the most nutrition. And then the other thing is to keep the mouth clean, so brushing after meals, brushing your tongue, because you can have food in the back of your tongue. If you have dentures, taking them out and cleaning them after every meal. And even if you don't have any teeth, just to kind of make sure that your mouth is clean. And that will all limit the amount of food that gets down. Yes? So the question is if it's two things at once are difficult. Reading is one thing. Yeah, anything that splits your brain. How about constipation? Well, there's some things that it's helpful to know so that your intestinal function, this is true for people with and without Parkinson's, is actually the best in the morning after breakfast. And there's a reflex where when you fill your stomach, then the colon wants to empty in preparation for the new food. So a regular bathroom time after meals, and also not trying to hold it, listening to your body's signals, and don't ignore the urge. It's important not to get too worked up or anxious, because that's kind of a sympathetic nervous system response, and that decreases intestinal movement. A lot of our patients don't drink enough water, and I understand why, because then you have to pee all the time. And so they just don't drink enough water. So drinking enough water is really important. Eating enough fiber is really important. And exercise is really important. So regular daily exercise increases the movement of foods through the colon. And then this has not been proven, but I sort of think it's cute. So I have a colleague who's a gastroenterologist who always talks about this. We weren't meant to sit and empty the bowels. We were meant to squat and empty the bowels. And so elevating the feet so it's more of a squat position rather than a sit position can make it easier for the defecation part, the eliminating the stool from the colon. And these are now, I did a Google search today, and you can get these anywhere. It's called what's it called? Squatty Potty. It's called the Squatty Potty. And they have them at Target now. They have them online. It's all the rage. And actually what my gastrointestinal colleague would say is just get a bunch of books and put them next to the toilet and then put your feet up on the books. So that's a really good, it's a really good strategy. Now, if that's not enough, which it frequently isn't, if the problem is really hard stool, then stool softeners are useful. So these are things like Colace is one. And also a lot of fiber. Fiber draws water back into the stool. And so a high fiber diet is really quite useful. If you need a laxative, you should stay away from the really potent ones like Dulcolax, because those can actually damage the nervous system supply to the intestines and make things worse in the long run. And then some people will become enema dependent if they take those powerful stimulant laxatives. But laxatives like Senna, which is a health food, it's available as tablets. You can also get a tea. Polyethylene glycol, which is Miralax, the white bottle with the purple cap on it, or the Wallalax, which is the white bottle with the purple cap. at the Walgreens shelf that's right next to it and half the price. And then another one that's over the counter is lactulose, which is a concentrated sugar, and that has the same purpose. It draws water in back into the stool. If those things don't work, then there are prescription drugs. So pyridostigmine is a drug that's used to treat myasthenia gravis. So if you're thinking to yourself you're in the wrong meeting, it's not. It helps myasthenia gravis, but it also helps to move things through the intestines. In fact, that's the most common side effect of the medicine is diarrhea, et cetera, because the intestines move more. So that one, and I often use that one for blood pressure regulation, which we'll talk about in a bit. So that can be a nice medicine to improve. And then there are all the ones that you hear about now on TV that are being advertised for irritable bowel syndrome. So these are all prescription medicines that are expensive, and they're best prescribed by a gastroenterology specialist who's used to working with these drugs, because these are much more potent kind of medicines with more potent side effects too. For this defecatory dysfunction, pelvic floor physical therapy can help to learn a new coordination for those muscles that are important in elimination. I think pelvic floor physical therapy can also be helpful for people who have bladder problems, so that's something that's a nice thing to try. And then here's an area where botulinum toxin injections can be used also into the sphincter, and this is for the people who have trouble relaxing that external sphincter. I don't think anyone certainly not in our group, does those, but gastroenterology people often do botulinum toxin injections for the muscles there. And this is my Martha Stewart moment, where I share my recipe for anti-constipation paste. This is a lovely recipe. It's actually really easy. So you get this, I told you that senna comes in a tea. You get the senna tea, and then you brew 2.5 cups of the senna tea. And then you get 3 pounds of dried fruit of your choosing, prunes, raisins, figs, whatever it is that you like. And then you put it in liquid, and you boil it until the fruit is softened. You add some brown sugar, or if you're on a sugar-restricted thing, you can put some that brown sugar Splenda in there, and a cup of lemon juice. And then you blend it into a paste with a food processor or blender. And then you get your Tupperware or generic Tupperware equivalent, and you put it in the freezer, and it's a sorbet consistency. So you can serve it to your dinner guests in between courses, if you have the kind of dinner guests that tend to be a little stopped up, or you can just take it 1 to 2 tablespoons a day. I did have one patient, wonderful lady in Chicago, who she had to keep it in the freezer in the garage because she liked it so much that she would eat it like ice cream, and then she was having all kinds of problems with diarrhea. So most people say it's quite tasty, and it lasts in the freezer forever. So it's a really nice thing. You just take a scoop out, a tablespoon out, and then you eat it. Patients really quite like this recipe. On to the bladder. So this is a nice picture of the kidneys and the bladder, right, and the ureters. And remember, like 100% of people with Parkinson's disease have one or more complaints about their bladder. So this is very common. And the kinds of problems, so the detrusor muscle, your bladder is just a big muscle, basically. And like the intestines, there's the muscle that squeezes the urine out, and then there's the sphincter, the muscle that you're allowed to control it so it just doesn't squirt out whenever your bladder is full. And so people with Parkinson's disease seem to have an overactive bladder muscle, the one that squeezes out the urine. And so that makes them to have what I would call an anxious bladder. So it fills. But before it ordinarily, before you had Parkinson's disease, you could hold a lot of urine in your bladder. But it has to empty earlier, so when there's less urine in there. And also, the first sign that you have to go is also the last sign that you have to go. So there's no waiting around until you go home. You got to find the bathroom in the Home Depot because you're not going to be able to make it home. So that's a really common problem. And this can lead to incontinence, what's called urge incontinence, where if you try to wait, or you just don't have enough time between the warning and when you can actually get there. And if you're slow, you can see how that would be a problem because it takes too long to get to the bathroom. So and the thing to know about the bladder is that there are lots of other things that influence the bladder. So bladder problems are really common with aging. So if you have a big prostate, or if you've had prostate surgery, or if you've squeezed out a lot of babies in your life, you're going to have problems with the control of the bladder related to that as well. So it's very common for those two kinds of problems to kind of conspire, or if you're diabetic, there are lots of other things that can cause additive problems. So sometimes bladder training is helpful, allows you to train your bladder to accommodate more liquid or to be a little bit more forgiving from when the first signal comes to when you have to empty. There are lots of drugs. All you have to do is sit down and watch a football game, and you're going to see all kinds of drugs about the bladder and sexual dysfunction and trucks. Those are the three kinds of commercials you see for a football game. And so this is just a bunch of them. And they all work to some extent. None of them is perfect. And usually I will try a couple, and then if I have to throw up my hands, then I'll send someone to a urologist who can actually do some tests to find out what the best one is. And here's another area where if the problem is a problem with relaxing the bladder muscle so that it's a little bit more forgiving, then actually botulinum toxins injections have been used for that as well. Those are done by urologists, not by neurologists. How about the cardiovascular dysfunction? So there's certain things that we know about the heart in Parkinson's disease. So when you're kind of at rest, the heart rate varies with whether you're breathing in or breathing out. And people with Parkinson's disease don't have that normal variability, which doesn't cause any symptoms. It may be a marker of early disease. The thing that causes the most problems with the cardiovascular system in Parkinson's disease is orthostatic hypotension. Anyone familiar with that terminology, orthostatic hypotension? So orthostatic hypotension comes from the Greek word ortho, which means straight, like orthopedics, and static, which means standing. So when you're standing up, what happens is the blood pressure falls. And the reason is because almost 1 liter of blood goes into the lower part of your body when you stand up. And that's a lot of blood. I mean, you got like 5 liters in there. So, when one is in your feet, that's a big difference. So less is in your head, so you feel lightheaded and dizzy, or you may pass out. And a significant change in blood pressure from laying down to standing up is 20 in the top number or 10 in the bottom number. So a decrease in blood pressure of 20 for the top number or 10 of the bottom number is considered significant within 3 minutes of standing. And people may not always be aware that it's a blood pressure problem. So they may feel lightheaded or dizzy, or they might just have blurry vision when they stand up. Or they might feel tired when they stand up. Or they might have neck and shoulder pain. And that's called the coat hanger syndrome, because it's your neck and your shoulders that feel that pain. Some people have pain right behind the eyes too, right behind the bridge of the nose. Some people just get goofy when they stand up, so they're not quite as sharp cognitively. Some people get chest pain, and the worst case scenario is loss of consciousness, or what we call syncope. And that's bad because you can hurt yourself when you do it. So usually our medical assistants in the clinic will check the blood pressure, sitting down and standing up, sometimes laying down and standing up. Or you will tell us about symptoms, and we'll have you check your blood pressure at home. And this is a slide called the ABCDs of treating orthostatic hypotension. One of the most effective that people tend not to use is an abdominal binder. So this, in addition to making you look all svelte and slim and trim in your midsection, that pressure in there causes the blood to redistribute from inside your abdominal cavity back where you need it. So that's actually a very nice way to treat it. B is boluses of water. So if you're feeling lightheaded or the blood pressure is low when you record it, drinking water, especially ice water. Ice water will raise the blood pressure almost instantaneously, and it will stay elevated for a period of time after you drink ice water. Sleeping with the head of the bed up is at night improves the blood pressure in the morning, which is a time when a lot of our patients have their lowest blood pressure after they've been sleeping flat all night. And by this, I do not mean putting pillows under your necks or heads like that. I mean a wedge that that elevates your torso, so your heart has to be elevated above the flat. Yep. Are big swings in blood pressure something to worry about? Yes, especially if they're associated with any of those symptoms. It's fairly common for people with orthostatic hypotension to have high blood pressure when laying down. So these are people whose blood pressure can be 150 over 90, 160 over 100 laying down, and then standing up, 80 over 60 or 60 over 40 or something. So it's especially problematic if you have symptoms when you're standing up. And one of the issues with If you're lightheaded or you feel like you're going to pass out, or you have the pain behind your eyes or pain in the neck and the shoulders, yeah. Well, if you're going to monitor your blood pressure, usually we want to tell your doctor about it, or if you pass out, you want to go to the ER. That's what happens if you pass out and it's your first time. Are you asking, if I'm not having any symptoms, should I test my blood pressure lying down and standing up? No. So I'm not sure I understand the question. I'm not sure I understand the question. It's not that I'm not understanding your words. I'm not understanding the question. Well, the question is not, it's partly what your blood pressure is when you're standing, but it's also the difference between laying down and standing up. Those are both important numbers. So if your standing blood pressure is less than 80/50, then you should talk to your doctor about that. If there's a big change in your blood pressure from laying down to standing up, you should talk to your doctor about that too. I don't recommend that people test their blood pressure routinely unless they're having symptoms when they stand up. It depends on the doctor whether most do the test automatically in the office. Some do and some don't. But I'm not recommending everyone go home with the blood pressure cuff and check their blood pressure laying down and standing up today and then call the office tonight. If you're concerned about it because you're having symptoms, you should check it. Or if you go to the doctor's office and the doctor's office confirms that you have a drop in your blood pressure from laying down to standing up, they may instruct you to check it. But if you're not having symptoms and your doctor hasn't told you to check your blood pressure laying down or standing up, I wouldn't be concerned with it, honestly. Does that make sense? Does that answer your question? No. Right. Talk to your doctor about it. Okay? One thing, so if you have orthostatic hypotension, it's amazing to me how people have listened to the message that salt is bad and they don't salt their food. So people who have no blood pressure when they're standing up are not salting their food. Well, salting the food allows more liquid to be kept in the arteries. And so it's a very good way to increase blood pressure. Salt the food. And then also, a lot of people have given up on caffeine for various reasons. But if there's not another reason you're not doing it, drinking caffeine before a meal helps with the drop in blood pressure that naturally occurs after eating. So after you eat, you're in your rest and digest mode. The blood goes to your intestines to digest the food. And so your blood pressure will fall when you stand up. And if you drink caffeine with your meals, then you counteract that tendency for the blood pressure to fall after eating. So caffeine and salt are good at mealtime for people whose blood pressure is low, unless they have a history of something like heart failure where their doctors told them they can't have caffeine or salt. But if you were told by a doctor to limit your caffeine and salt, and you feel lightheaded or dizzy when you stand up, and your blood pressure is low, salt and caffeine is something we commonly recommend to people. There also are things you can do, like if you're standing and your balance is good and you feel lightheaded, if you just cross your legs, you increase the amount of blood that returns back up into the upper part of your body. Or if you raise your toes up, any kind of muscle contraction there, or contract your thigh muscles, or bend over at the waist, or march in place, or elevate the legs. All of those things increase the amount of blood that's returned from the lower body to the upper body. And those are helpful for counteracting the blood pressure issues. And then all else fails, then there are certain medicines. So Florinef or fludrocortisone increases sodium reabsorption by the kidneys. And so it's the same thing as salting your food, basically. But you're getting more salt in your system, which means you get more water in the system. And that's a prescription medicine. Pyridostigmine I mentioned earlier, which can help with constipation. That medicine also improves blood pressure. It's a myasthenia gravis medicine that can improve blood pressure. But the ones that are approved for the treatment of Parkinson's disease are mitidrine, or proamotine is its other name, and droxidopa. And these are both medicines that elevate blood pressure, and they're by prescription only. And droxidopa costs, I don't know, $1 million, something like that, because it's new. And everything new costs $1 million. So this is the kind of thing, this is not the kind of thing that you diagnose or treat at home. This is the kind of thing you talk to the doctor, you say, I'm feeling lightheaded when I stand up, or I have this pain in my shoulders. The doctor checks your blood pressure, recommends which of these things you should do. These things are useful to know about the drinking and the salt and the caffeine and these kinds of counter maneuvers, because in the context of what your doctor tells you to do, these things can also be helpful, especially if you're having a problem today and you want to drink some ice water so that your blood pressure is better. So thermoregulate, this is a big complaint, thermoregulatory dysfunction. So this is the ability to keep your body temperature, your core temperature, 37 degrees centigrade, which is the normal, or 98.6 degrees Fahrenheit. So we're warm-blooded animals. Our metabolic system generates a certain amount of heat, and we maintain our body within a very normal, very narrow temperature range. And the way we do it is by using the parasympathetic nervous system and the sympathetic nervous system. So, and what this parasympathetic nervous system, the rest and digest one, and the sympathetic, the fight or flight part, do is your body temperature, your central temperature is detected. And if it's too high, then you do things like dilate your blood vessels so more of the blood goes to your skin. The hairs on your arm lie flat so they're not insulating the skin. You don't have goosebumps because goosebumps thicken your skin and make it a better insulator. And you sweat. So these are all things you do when your body temperature is too high. And when your body temperature is too low, you vasoconstrict, which means your arteries constrict, so more of the blood flow is central and less of it goes to the skin. You get goosebumps, so that thickens your skin, which makes it a better insulator. The hairs stand up on your arm, which gives you kind of the fur, the fur holding keeping the warm air close to the skin and keeping you warmer, and you don't sweat. So that's all a very delicate balance, and you can see here the net effect of this when you're warm is all the blood goes to the surface of your body so that the heat can dissipate and the sweating. And so what happens is your insulating shell is very thin. You don't insulate well. You don't keep that heat cooped up inside you. Whereas when you're cold, the blood tends to concentrate centrally. All the reasons I told you, you've got this insulating shell that keeps you warmer. And this system that controls whether your body is warming up or cooling off is autonomic nervous system. And so you can imagine that it's abnormal in people with Parkinson's disease. And usually the number one complaint of disordered thermoregulation is sweating. So about almost 2/3 of people with Parkinson's disease, I heard this twice in one day just last week in the clinic, report abnormal sweating. And it's embarrassing. People have to change their pajamas, sometimes change the pillowcase at night, or bring a change of a shirt when they go somewhere. But the interesting thing about it is it's not your whole body sweating. It's that there's an asymmetric or localized sweating. So for the most part, the sweating occurs on the face, the head, and the trunk. And in fact, studies of sweat distribution in people with Parkinson's have shown that the sweat on the limbs is much less. So it's as if all the sweat is coming out in this one area and it's not being evenly distributed across the body. And it's most problematic in people who have motor fluctuations when they're having on periods of good function and off periods of poor function, either when they're off, so the medicine shuts off and they start to sweat, or sometimes when they're having a lot of extra movements. And these are just challenges where it's harder to thermoregulate, and since the system's not working properly, those are the times that people mainly notice this thermoregulation problem. And like all these autonomic nervous system things I've talked about today, there has been inadequate research to really know what the best strategy is. This, I would say, is a complaint that's very, very common and very annoying, but has very poorly understood because the research has not caught up to the importance of the problem. And so things you can do is avoid triggers, dress in layers so that you're able to decrease your own insulating shell by taking the layers off. Avoid things that make you, hot rooms, crowded rooms, for example, things that make you stressed out. Avoid stress. Using an antiperspirant, although you can't, all over your, I suppose you could. Natural fabrics that breathe better. And then because so much of the problem is when people's drug wears off or when they're having this dyskinesia, this over-medication effect, changing the medicines to give people a smoother function during the day often will help with this. And some medicines that block the chemical acetylcholine, so for example, that medicine I mentioned called glycopyrrolate that I use sometimes for drooling, sometimes that helps for sweating. And I've tried various things but I've never been happy. And botulinum toxin, so this is the same chemical. The chemical that's released by the nerves to trigger sweating is the same chemical that's released by the nerves to trigger drooling. And so botulinum toxin, because it blocks that chemical release, can also be useful for sweating. And before the Oscars, all the starlets get free botulinum toxin into their armpits. And so it may be that if there's a localized sweating, you might be able to do it. But I don't think you wouldn't want injections all over your torso and your head and your neck. So this would be for really kind of special cases, I would say. And then finally, let's talk a little bit about sexual dysfunction. Doctors don't usually want to talk very much about this. And sometimes the patients don't want to talk about it, but it's very common. So this is from a study in 2010, and it's not even in a Parkinson's journal. It's in the Journal of Sex and Marital Therapy, so this is not something that, not one of my regular journals to read, for example. And looked at women and men. Women have, and they looked at the arousal part of sex and also the orgasm part, but also the desire, so libido. And women have almost 90% problems with getting aroused properly, 75% difficulty with orgasm, and they're not terribly satisfied with their sex lives and problems with desire. And the sicker you are and the more depressed you are, the worse it is. And then with men, erectile dysfunction, more than 2/3, premature ejaculation, 40%, problems with orgasm, about 40%, and 65% dissatisfied with the quality of their sex life. And just like with the bladder, there are a lot of things that can cause additive effects. So for example, depression. Men who've had prostatectomy have a higher risk of sexual dysfunction. The dopamine agonists, so the ropinirole, pramipexole, ratigatine medicines, seem maybe to have more of an effect on this, a more severe disease. A lot of the antidepressants causes a side effect, sexual dysfunction, especially changes in ejaculation or in desire, libido. And then also cholesterol problems and diabetes, anything that affects the nervous system. Additionally, kind of on top of the Parkinson's can cause these problems. And that's it.